Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. Chris Parker from the Institute of Cancer Research in Royal Marsden Hospital in the United Kingdom, and Dr. Bertrand Tombal from Université Catholique de Leuven in Belgium. They will be discussing recent data from the ASCO 2021 meeting focusing on using radium-223, PSMA lutetium, and bone health approaches for the management of patients with metastatic castration-resistant prostate cancer, as well as touching on ongoing trials evaluating radiopharmaceuticals in combination with other agents for these patients. This episode is part of a larger educational program titled Current Topics in Oncology, a focus on prostate cancer. For more information on Dr. Parker and Dr. Tombal, along with a link to the complete program, including a downloadable slide set covering the content of this podcast, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Hello everyone, my name is Chris Parker. I'm a prostate oncologist at the Royal Marsden Hospital in the UK.
Hello everybody, I'm Bertrand Tombal. I'm a urologist from Brussels, Belgium, but doing so far only onco-urology. And we are pleased to be here with Chris to discuss a few hot topics. And indeed, it's becoming, I would say, a little bit more complicated to treat these advanced cancer patients. When I have a look at the field, actually I see something which goes to my mind as a urologist working on hormone therapy, is that slowly we are moving back to maximal androgen blockade, something we, the urologists, we knew very well. At the time, we would combine enzalutamide to everybody we would give hormone therapy. And it seems that this is where we're moving so far with the new hormone, enzalutamide, maybe one day darolutamide, so that today, basically, even the traditional description of a castration-resistant prostate cancer has evolved. Today, I would say where the debate starts is what do you do when somebody has been on androgen deprivation therapy and abiraterone, enzalutamide, or apalutamide. This is already common because we had many patients going in clinical trial, and it's going to be more and more. At every stage of the disease, it seems that we're going to use a combination of ADT and one of these hormones. So the landscape today, that's where after that we have some difficulties, because we have the question about what is the role of docetaxel today. I must say in my practice, whenever we can, we tend to put docetaxel, I would say docetaxel first. We still use it a lot in high volume prostate cancer patient, and we're looking with a lot of anxiety at the result of the combination to see whether we should use it as a triplet combination. And when the patient is progressing, whenever we can, we tend to give docetaxel as well. So it's still there, although it's the oldest of all the drug we have. We have gone, I think, beyond the hormone after hormone, and that I would be happy to see Chris' view. I mean, honestly, when we have patient progressing on abiraterone or enzalutamide or apalutamide, we tend less and less to give and back-to-back hormone, although we must say that in patients with very prolonged response, sometimes we see some response. And then we have radium, which Chris will give in more detail. But so far, this was basically what we had at second line, and in the patient who responded to docetaxel, especially those who had a short response, cabazitaxel is a great drug. And as we're going to discuss today, we have more options. We have PARP inhibitor, and we have the emerging field of theranostic. So really the question is, where are they going to fit? But as a summary to my introduction, I would say that today the question is, what do you do when somebody is progressing on, I don't know, triptorelin and abiraterone? And that the only thing we have learned so far is that we probably know the less effective treatment, which is to give another hormone. And we have chemotherapy, but everybody's not chemotherapy. And then really that's an interesting debate.
Thanks, Bertrand. I think our approach is quite similar. So most patients have already received abiraterone or enzalutamide in the hormone-sensitive setting. So by the time they get to be castrate refractory, the standard option is to go for chemotherapy, and the alternative to go for something like radium-223. So we're going to focus now on recent data on radionuclides. We're going to talk about radium-223 first, and then we're going to move on to PSMA lutetium. And so there was some recent data presented at ASCO from the PEACE-3 trial. This is a randomized phase 3 trial in men with metastatic CRPC, comparing enzalutamide alone versus the combination of enzalutamide plus radium-223. So the design is very similar to the rather ill-fated Uro-223 trial. That was a trial, if you remember, of abiraterone with or without radium-223. And rather surprisingly, that failed to show any advantage for the combination of Abi plus radium compared with Abi alone. And it did show a significant disadvantage because there was an increased risk of fracture in the combination arm. So the data that was presented at ASCO from PEACE-3 is focusing on the safety and in particular the risk of fracture. Now, when the trial first opened, the use of bone protective agents was optional, and the risk of fracture was really substantial. So in patients getting enzalutamide alone, more than 20% were developing fractures. And in the combination arm of enzalutamide plus radium, that was approaching 50%. So at that point, and with knowledge from the Uro-223 trial, bone protective agents were mandated. And the results that we now see are extremely encouraging, with fracture rates of less than 3% for enzalutamide alone and around 4% for enzalutamide plus radium. So I think this is a really important outcome, demonstrating that it must be mandatory for our patients to receive bone health agents. And I think the use of bone health agents has completely changed over the last 20 years. So 20 years ago, they tended to be used late, they tended to be used frequently, so we had intravenous schedules of zoledronic acid every 3 or 4 weeks. And the hope was to prevent skeletal-related events, things like pathologic fractures, consequences of metastases. So what we're seeing now is completely different. We're using bone health agents early. We're using them to prevent fragility fractures. This is a bone health issue. It's not a bone metastases issue. And the doses can be very low. So in my practice, I'm using an oral bisphosphonate started at the same time as men start long-term hormone therapy. So we're not trying to prevent pathologic fractures. We're not trying to prevent skeletal-related events. We're trying to maintain bone health and prevent fragility fractures. And if you really want to use intravenous zoledronic acid, then every 6 months or every 12 months is enough to prevent fractures. How do you see things, Bertrand?
Yeah, no, I mean, I fully agree with you. I mean, many times people telling me, but you know, in the PEACE-3 trial, are you not using too much of bone protecting agent? So I think I try to remind the context. The context is the one you described with the kind of catastrophic event with ERA-223. So we had to take a quick decision. And because these patients were metastatic and castration resistant, the only registered dose of zoledronic acid and denosumab was the one, the very high dose used, like you said, later on in the disease. So we had to deal with a huge number of ethical committee, regulatory body, and we had to take that extreme decision. No, I like to say that my practice is close to yours. I think that what we have learned, like you said, is that osteoporotic fractures are something that happen and that can be very detrimental to the patient. So the primary recommendation is please monitor bone health. We do DEXA scan on a regular basis. I rather like low dose denosumab, you know, and we only escalate to the full dose when the patient has a substantial number of metastases. And also something we tend to forget is that when we did the denosumab and the zoledronic acid, there was no drug to induce a massive response in the bone, like we see sometimes with enzalutamide and abiraterone. So if you start with a patient with many bone metastases, you can end up with a patient with minimal bone metastatic burden. So I think that, like you said, we should revisit, and we don't have a lot of data to do that, but we should revisit this interplay between pathological and non-pathological fracture, and keep in mind what is the objective we want to do. Because if we want to reduce frailty fracture, the standard SRE preventing dose, that's clearly too much.
It's I think it's the first time, Bertrand, that you and I have agreed, and we've always disagreed in the past.
But we unfortunately agree because we both had made mistakes. So I was very interested.
That's a fair comment, actually, isn't it? Probably I never used enough bone health agents in the past, and maybe you used more than necessary.
And I realized that, the problem is that people have not realized that pathological and non-pathological fracture are two different things, that you are treating two diseases with the same drug, which is extremely complicated. Yes. And we have a huge work on education to do. Yes. To understand when do you switch, when do you escalate, when do you de-escalate.
Great, we agree, that's great. So Bertrand, would you like to move on to tell us a bit about the new data on PSMA lutetium?
Yeah, I think that in 20 years from now, we're going to call radium the predecessor, because this is really the one that actually changed our view on the important role of radionuclide in prostate cancer, because so far I've been always a fan. I use a lot drug like samarium, strontium, but it was only for palliative. So clearly we were expecting the result of that phase 3 trial. The difference between PSMA lutetium and radium is that lutetium is a beta emitter, it's not an alpha emitter, and it's actually coupled to PSMA with the hope to target the drug, and primary to target it outside the bone metastasis, because radium being an analog of calcium, it goes only where bone metastases are. So we had promising result from from an Australian trial. So the VISION trial was really expected. So it's a standard trial. And I think that trial is important because in many countries, people have started using PSMA lutetium without having the phase 3 result. I think this was very important to have a clear idea of what we are expecting. We are exactly in the setting we were discussing before, somebody which has received at least one line of androgen receptor pathway inhibitor and 1 or 2 taxane regimen. So clearly, what I like to call the third line, not taking into account ADT. So the control arm was a standard of care, although they call that protocol permitted standard of care, meaning that chemotherapy and radium-223 were excluded. And honestly, looking at the hazard ratio of all these drugs, I would like so much to have a kind of stampede where you have either cabazitaxel, radium, or PSMA lutetium. So actually, it did show a nice benefit in overall survival. It's in line of what we've seen with other drugs. I mean, it's in the range of the magical 0.6 to 0.7. So, but it's heavily pretreated patients, so a nice benefit in overall survival. And then a difference with the radium trial, and you may comment on this, Chris, afterwards, is that actually they look more at secondary endpoint. So there is more documentation on the PFS and the PSA response, which always has been a difficulty people have with radium. Here we have a very nice PSA response, and we have a nice effect on the PFS. There are some caveat and interesting discussion, though. The first one is that PSMA is a targeted therapy, meaning that you need to get PSMA expression. And we know that in the third, fourth line setting, there is an increasing number of patients who have actually PSMA negative trials. So meaning that in order to be included in the trial, you need to have a PSMA dominant gallium PSMA. There are a lot of questions today. Do you absolutely need a gallium PSMA to receive PSMA lutetium? I would say yes, because it's a targeted therapy. The toxicity is interesting. And actually, when I look at the toxicity the first time, it reminds me more of the toxicity of samarium and strontium than of the toxicity of radium. Beta emitter have a longer range of action than alpha emitter. So you see a little bit more hematological toxicity. So it's absolutely not prohibitive, but keep in mind that at some point we're going to have to discuss the articulation between cabazitaxel and PET PSMA. So this may be something we're going to have an additional look in the future. But in the end, it's one more treatment in the armamentarium. People should understand that lutetium and radium are profoundly different drugs, so they probably have both an important role to play in advanced patients. And I think that we're going to learn more in the next months about the benefit. At this point in time, the hazard ratio being 0.6, we can say that we have no, if you have received an ADT and an AR pathway inhibitor and docetaxel, we have no 3 drugs. We have cabazitaxel, we have olaparib, and we have PSMA lutetium.
Thank you. Yes, I agree. It's clearly an effective therapy. Particularly interesting that you get some really exceptional responses. So some patients have a profound fall in PSA and a very long duration of response. And in fact, in my practice, when you get these exceptional responses, we're stopping treatment after just 1 or 2 cycles rather than continuing, with a view to restarting treatment on progression. And in some cases, that delay can be 18 months or even longer. And as you say, this does mark it out as different from radium-223. So we're going to move on in the last section now to talk about the future of radionuclides in metastatic CRPC. So this is, of course, a bit of speculation. There are a couple of radium trials that I'd like to mention. The first is the DORA trial, which is comparing docetaxel used as a single agent versus the combination of docetaxel plus radium-223. Now, there is, of course, a very long history of negative docetaxel combination trials. So if this trial were to show an overall survival benefit, it would be the first of all the docetaxel combination trials. I'm mindful of the fact that the dose of docetaxel has had to be reduced in the combination arm, and the frequency of radium has also had to be reduced in the combination arm. So we'll see what the data show. And then the other trial, which is ongoing, is comparing radium as a single agent against a second AR-targeted drug. So in patients with prior abiraterone, it's enzalutamide, and in patients with prior enzalutamide, it's abiraterone. Now, I think this trial might be hard to recruit because at a time when patients could have chemotherapy or they could have PSMA lutetium, the thought of a second AR-targeted drug, as Bertrand mentioned earlier, is not particularly attractive. So we do know that the control arm of this trial will be relatively inactive. However, if they do manage to recruit, it'll be interesting to see how radium compares. And so looking ahead, first of all, when it comes to radium, what's made most difference in my practice is the use of diffusion-weighted whole-body MRI to assess response. So in the past, we used to give 6 cycles of radium regardless, hoping that patients were benefiting, but not really knowing. Whereas now, we can actually measure response in bone metastases on whole-body diffusion-weighted MRI. And to my mind, that makes it much easier to determine whether to continue radium or not. Some patients get a very nice response, other patients don't. But I suppose a lot of the excitement at the moment is around PSMA lutetium, and in particular, how to best use it. What's the optimum dose schedule? What's the optimum combination with other drugs? Will it work better if we're using it earlier? How about other radionuclides targeted using PSMA? A lot of interest at the moment in PSMA actinium. So this is a fast-moving area with a lot of research. Would you like to finally wrap up, Bertrand?
No, I think that we are once again living in a very interesting period where a few years ago we had no treatment for metastatic CRPC, then we had no treatment for newly diagnosed, and then here we were living for 2-3 years with no treatment for only 2 treatments for those beyond progression. So we have no 4 drugs plus many other on the horizon. So it's going to be very exciting. And the only thing is that we must keep putting these patients in clinical trial because we don't know a lot. We need to better understand use and combination. So it's a great time, but we should not waste it.
Thank you very much, Dr. Parker and Dr. Tombal, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, current topics in oncology, a focus on prostate cancer, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.